Good day, this is Michelle Levander, editor of Reporting on Health, an initiative of the USC Annenberg School of Journalism in Los Angeles. Thanks so much for joining us for our one-hour webinar, Insuring the Uninsured and the Medicaid Expansion. President Obama's Affordable Care Act, sometimes known as Obamacare, offers states an unprecedented opportunity to provide insurance to the uninsured. Medicaid, of course, is a government health plan for the low-income and sick, and under the Affordable Care Act, new categories of people will be eligible for it. The federal law will cover 100% of the costs for the first 3 years of each state's Medicaid expansion and subsidies in the years that follow. But states have the right to accept or turn down these government subsidies. And as it turns out, turning down that subsidy isn't so easy. Several formerly staunch opponents of the expansion have begun to waver or change their positions. Some of the Republican governors who initially opposed the expansion, including Chris Christie of New Jersey and Rick Scott of Florida, now say they will accept federal money to expand the program. And as we hold this webinar, advocates of expansion in Texas plan a rally that is to be attended by hundreds of uninsured and advocates trying to pressure Governor Rick Perry and others to change their position on the Medicaid expansion. We have 3 distinguished panelists here who will help us to make sense of all this. We'll start off with Weil, Executive Director of the National Academy for State Health Policy, an independent, nonpartisan think tank in Washington. Becca Aaronson, who reports on health care and develops data interactives for the Texas Tribune, will share her strategies for covering this important issue in a red state, with a governor who has criticized the Medicaid expansion as socialized medicine. Then we'll hear from Martha Bebinger, a veteran healthcare reporter at WBUR, the NPR affiliate in Boston. She will share ideas for reporting in a blue state and a place where the healthcare expansion took place several years before. And with that, I'm going to turn this over to Weil, our first speaker. Thank you, Alan.
Thank you, Michelle. My name is Weil. I'm the Executive Director of the National Academy for State Health Policy, and I appreciate the opportunity to talk to you about all that's happening with Medicaid in the Affordable Care Act. In the time I have with you, I'm going to discuss how the Affordable Care Act affects the Medicaid. Talk about the Medicaid expansion, which has received a significant amount of attention. But there are many things in the Affordable Care Act that go beyond the expansion as they affect Medicaid. I'm going to talk briefly about how Medicaid is related to the health insurance exchange, and note that there will still be some people without health insurance after the Affordable Care Act is implemented. And I'm going to try to cover this all very quickly. So let's just start with an overview of what's in the Affordable Care Act that affects the Medicaid program. First of all, coverage eligibility standards are locked in place for adults through this year, and for children, both the CHIP and Medicaid eligibility standards stay in place through 2019. You've undoubtedly heard that the law includes an expansion of coverage to adults up to 133% of the federal poverty level without regard to their family structure or assets. That goes into effect January 1st, 2014. And just so you understand, under current law, adults, if they don't have children or they are not disabled, are currently ineligible for Medicaid, no matter how poor they might be. These newly eligible adults will be eligible for either the traditional Medicaid benefits, which are quite comprehensive, or at the state option, they can be provided with a so-called benchmark benefit package, which is much more like commercial health insurance. This expansion is paid for entirely by the federal taxpayer for the first 3 calendar years, 2014 through 2016. The 100% federal match rate phases down 95, 93, 92, and then to 90% in 2020 and thereafter. And as you no doubt know, the Supreme Court said that this Medicaid expansion provision in the Affordable Care Act could not be mandatory, and so the federal government cannot penalize states that decline to take up this expansion option. So when we're looking at the Medicaid expansion, there are really 4 ways to look at it, through the perspectives of coverage, cost, health, and health system performance. Let's start with coverage. You have to begin with an understanding of who is currently uninsured. The information I have presented here shows that for people below the federal poverty line right now, only about 1/4 of them have private coverage. A third have Medicaid, but 40% are uninsured. Of course, the uninsured rates decline as your income goes up, and the availability of Medicaid declines because Medicaid eligibility is tied to having low income. So what happens with the Medicaid expansion? The Urban Institute did some estimates of what Medicaid would look like in the year 2022. They estimated that if we hadn't passed the Affordable Care Act, there'd be about 52 million people enrolled in the Medicaid program. If no state chooses to expand, that enrollment would go up to 58 million. And if all states elected to expand, we would have almost 74 million people on the Medicaid program in 2022. So you can see that this is a very significant expansion, and the size of the expansion depends very much on the decisions that states make. What happens if we go through this expansion? Well, we'll see a very significant reduction in the number of people without health insurance. Again, according to the same estimates, the number of uninsured in the United States would be only 28 million people in 2022, whereas it would have been 53 million without the ACA. So we're basically, if all states took up the Medicaid expansion, we would cut the number of uninsured about in half. Now, what does this all cost? Medicaid is a large and quite expensive program. So whenever you hear numbers about how much it costs and how much it's going to cost a state, you have to keep those in perspective. In the 10-year period, 2013 to 2022, even if we hadn't had the Affordable Care Act, we would be spending more than $6 trillion, that's with a T, more than $6 trillion over that decade on the Medicaid program. Those are the two large wedges in the slide that you can see. What does the Affordable Care Act do? It adds about $1 trillion to that baseline, assuming all states elected to expand Medicaid. And what you can also see here is, as I noted earlier, the absolutely overwhelming majority of that cost is borne by the federal taxpayer. The marginal increase in cost to states is less than $80 billion over that decade, which of course is a very large amount of money, but not large compared to the size of the program. What about the effects on people's health? We now have very clear evidence from a number of very well-designed studies that show that having Medicaid coverage reduces illness and it reduces death. These are slides from one such study by Summers, Baker, and Epstein. They compare states that expanded Medicaid with states that did not, and on the right hand, which is on the right-hand side, and on the left-hand side, you can see mortality rates are lower after the expansion in expansion states than in the control states. As I say, there are a number of studies that reach similar conclusions, but the evidence that Medicaid actually improves people's health is quite unambiguous. The other lens to look at the Medicaid expansion is the lens of health system performance. This is a very complicated topic that I'm not going to cover in much detail today. But do understand that expanding Medicaid provides more continuity of health insurance coverage, making sure that people don't have spells of being uninsured. It improves care continuity in the sense that people can see the same doctor as their income changes so that they can better manage things like chronic conditions. A larger Medicaid program can measure healthcare quality in ways that are aligned with other healthcare systems, and ultimately Medicaid can, if the state chooses to do so, align how it purchases care and how it reports on quality with other programs. As I say, these are very important provisions that get far beyond what most people talk about is at stake with the Medicaid expansion. So where are we? The advisory board has prepared this map, which gives a very quick picture of where states are in the Medicaid expansion. The red states are leaning against or have chosen not to participate. The bluer states are planning to participate. This is a very helpful way of looking at it, but we prefer to take a slightly deeper look because the considerations that states have in mind as they make their decisions are quite complex. These data are from a project that we run called State Reform. And on our website, we're not just tracking states' Medicaid decisions, but we're asking, what has the governor said? What's the legislature's position on the expansion? What analysis has been done of the fiscal implications or of the health implications? These are many factors that states are looking at as they make their decisions that go beyond a simple pronouncement by the governor, which is what often gets reported. But let me move on to issues in the Affordable Care Act that affect Medicaid, in addition to the expansion, which is the one that people focus on the most. Again, I'm going to not do these topics justice, but to quickly walk through eligibility and enrollment systems, dual eligibles, health homes, and reduced funding for safety net hospitals. Let me start with the topic of eligibility systems. As the Medicaid program expands and as we bring millions of people into health insurance exchanges, states are required to upgrade the eligibility systems that they use for these programs. This chart was very recently released by the Office of Inspector General at the Department of Health and Human Services, showing that the vast majority of states are in the midst of doing significant upgrades to their eligibility systems. Note, however, that it is not all states, and also be aware that these upgrades are very complex and don't always go so smoothly. They're certainly worth keeping an eye on to see how they evolve. A second area beyond the expansions is so-called dual eligibles, people eligible for both Medicaid and Medicare, the frailest and most vulnerable among us. Many states are participating in a new federal demonstration program designed to improve coordination of care for people who are participating in both of these programs. And on this map, you can see the states that are pursuing different models, or in the orange, the states that are not pursuing this demonstration at all. I should note that as of today, 3 states, Massachusetts, Ohio, and Illinois, have been approved for these demonstrations. The rest are still awaiting approval by CMS. This is a major area of focus for states in Medicaid that goes far beyond the expansion. A third area is so-called health homes. This is Section 2703 of the Affordable Care Act that provides significant additional federal funding so that states can improve care management for people with chronic conditions. The early states participating in this program focused primarily on those with severe and persistent mental illness, a very high-cost population within Medicaid. Again, on this map, you can see which states are active, which states are pursuing these kinds of programs within the Affordable Care Act. And the final area that I will mention is that safety net hospitals have traditionally received funding through a program called the Disproportionate Share Hospital Program. Payments to those hospitals are slated for reduction under the Affordable Care Act under the assumption that the number of people without health insurance will decline, and therefore the burden of uncompensated care will go down as well. This graph from the Congressional Research Service shows you how the funding is cut, as much as $4 billion a year over the deepest part of the cut. The cuts are restored at the end. That's a quirk of federal budgeting that I will only get into if you have questions. But you should be aware that the safety net hospitals in your states are going to experience significant financial pressure as a result of these cuts, that pressure being even greater if the state chooses not to expand the Medicaid program. I'm just going to close with 2 other topics that I alluded to at the outset. These are both very complex topics that, again, can't be the focus of a presentation just on the Medicaid program. The first is the relationship between Medicaid and the health insurance exchanges. This graph from a paper by Summers and Rosenbaum demonstrates that people with modest incomes have a great deal of fluctuation in their income levels. And as a result, they are very likely to move from one program to another. Remember, I mentioned earlier the issue of redesigning eligibility systems. This is part of why they're going to be so important. So if you take a cohort of adults with income between 133 and 200% of the federal poverty level, which means that they are eligible for tax credits but not Medicaid, and you look at them over a 4-year period, according to this work, only about 1/3 of them will always have income in the tax credit range. But more than 40% will bounce in and out of Medicaid and exchange eligibility, the orange group here. And about 1/4 of them will fall to Medicaid eligibility and stay there. So transitions across these programs are going to be very important. And this is very complicated because people's circumstances change frequently, and our eligibility systems have to keep up with people as their circumstances change. The final topic that I will just mention is that as much as Medicaid expansion, even if all states take it up, is important, there will be tens of millions of Americans still uninsured, even if all states chose to implement the law. As you can see from this work by the Urban Institute, about a quarter of them are undocumented immigrants, a population that receives a great deal of attention. But there are other reasons people will be uninsured. They may be eligible for Medicaid but not enrolled, which is actually the largest group on this chart. They may be exempt from the mandate because they don't have access to an affordable option, or they may have an affordable option but choose not to take it and pay the penalty that comes with being uninsured under the Affordable Care Act. So this is, again, a group to definitely keep an eye on. We are not eliminating the problem of the uninsured in this country with the Affordable Care Act, even if we make significant progress. My final slide is just to show you the link to the State Reform Project, which is a project at the National Academy for State Health Policy. We have more than 5,000 registered users, more than 2,000 state documents related to healthcare implementation. The site is not designed for the press, but it's certainly open to the public, and you can find a great deal of information about what states are doing if you look on that site. And I would just close with my information, my contact information. We are a nonprofit. We have a public service mission. And if we can be of any help, either answering questions or connecting you to state officials, we'd be happy to do so. I even have a new blog, and the link to Once in a While is here on this final page. I'm happy to answer your questions after we hear from our other two presenters.
Thank you so much, Alan. That was really helpful. We're going to turn now to Becca, who's going to take us into the trenches of reporting on these issues in Texas. Becca, are you ready to go?
Yep, I'm ready.
You're on.
Hi, everyone. Hi, everyone. My name is Becca. I'm a health and data reporter for the Texas Tribune. If you haven't heard of us, we are a nonprofit online news organization, and we specifically report on Texas politics. So the Medicaid expansion is, of course, a really big deal in Texas, and if you hadn't heard, Governor Perry does not support it. So in reporting on Medicaid expansion in a state like Texas, where the main political leadership is so obviously against it, you have to look at going beyond the obvious. As Alan kind of hinted, it's a lot more complicated than just the governor's position. There's been a lot of different options put on the table. For example, some have suggested maybe counties should be able to expand Medicaid on their own. Other people have said, well, maybe we should have a constitutional amendment and allow Texas voters to decide. The way that you find things out, though, is by really understanding where everyone's coming from. So the first place to start is to think about, what do the Republicans like Governor Perry really want? Where does their opposition stem from? If you've noticed in other states, they've made compromises with the federal government. So if Texas is going to reach a compromise, what will that actually look like? What will Republicans really be pushing for? So you can see from my slide, this is kind of what they've been saying here, although it's different in every state. They want a no strings attached block grant, which basically means flexibility to fix the program by either implementing co-pays, so that people have to take individual responsibility for their care and they can contain costs, or by subsidizing private coverage, similar to kind of what Arkansas has proposed. You want to understand the basic arguments from both sides and have that within your reach at any time, so that when you're talking to people, you can kind of figure out, based on other people, where they specifically stand and how that'll actually factor in to the long-term political outcome of this issue. So after you get a grip, you want to reach out. The first people to talk to are, of course, the people that would stand to lose if the state doesn't expand Medicaid. I've got a list here, but there's a whole bunch of people who have a vested interest in this issue. So the first people that I reached out to was the hospitals because they've already taken cuts to finance Medicaid expansion in their payment rates for Medicare. So they, of course, are lobbying fairly hard for the state to expand Medicaid so they don't lose out on billions of dollars. The best people to talk to are advocates and lobbyists because they know what's going on. Even if you're not going to report what they say, just talking to people and getting a sense of where different people stand on the issue will give you ideas. For example, that's where I heard about the idea to perhaps let counties expand Medicaid. And that's also where I found out that that's actually not what most people think is the best option because the state's already using a lot of local government county money to bring down this Medicaid transformation waiver and do new programs. They don't really have the money, basically, to do that. Pretty complicated stuff, but it's important. There's a lot of different things going on all at the same time in healthcare, so you need to kind of have your hands on all parts to see how it all fits in. And because it's so complicated, one of the best things you can do is simplify it for people. That's one of the reasons why in my reporting I tend to use a lot of interactivity. That means interactive charts, interactive graphs, interactive maps. If I can get the information to my audience in more ways than one, then it's easier for them to understand and make a reasonable judgment on their own. Engagement kind of makes the story, or interactivity allows readers to engage with the story so they can understand it in a way that or I guess understand how it affects them directly. And it's fun. If you can delight your readers, if you can entertain them, then they're going to spend more time with your stories. So if you want to, so before I show you some examples of what I've done, the best place to start when you're looking for information on something as complicated as Medicaid expansion is, check with organizations like Allen's. Start with your state health agencies, gather lots of information, and then learn how to look at the data. If you're going to build a graph or something, you'll probably want to learn some Excel tricks, which I can talk about later. And then think about what the data is telling you. So what's the story? Governor Perry doesn't want to expand Medicaid, but there's a lot of political pressure and resistance to that position. Why? What are people saying? What are the facts that they're relying on? And how can I present those people in a way that makes sense? And what do your readers want? They want to know how it's going to affect them. That's always what readers want, because otherwise it's not really that important. So here, for example, is a chart that I've made. I'll show it to you live. I understand that there's a little bit of a delay, so I will try and move slowly. So this first graph shows Medicaid enrollment under the expansion. And then if I click on this, you can see compared to the baseline, which is how many people are already enrolled, or will be anyways, without the expansion. So this is a quick way of allowing readers to see how much of a difference it will make in enrollment, which is a big factor for people, especially when you think that when there are lots of problems in the existing program. This graph down here shows federal spending compared to state spending, which, as you can see, is a big difference. The other thing that you can do is you can show maps. So this map that I made shows by Senate and House district the economic impact that Medicaid expansion would have. So how much local tax revenue would be brought in by the stimulus created by the extra federal money that's coming in. This way, if someone lives in Dallas, they can zoom in and they can see just how much money will be brought in to their district. They can see the name of their legislator who they might want to contact, and they can compare it to the regions around them and see how exactly it will affect them. So, oops. So if you have any questions, feel free to contact me. And yeah, that's it.
Great. Thank you so much, Becca. I really appreciate that. We're going to turn right now to Martha Bebinger, who's really a veteran health reporter and who's sort of lived through what we're all going through now in Massachusetts, which got started with all this stuff a little earlier.
Hi, everybody. Thanks so much for being here. I am going to talk to you about the expansion of health insurance coverage as a great social experiment, which I found it to be in Massachusetts, made it much more fascinating both to cover as a reporter and I think also for our listeners and readers. So we started in 2006 with a law that was aimed at near universal coverage. You can see, I hope, with that chart at the top, that the change in enrollment between the first year that the law was fully in effect in 2007 and 2008 was pretty dramatic. The number of people who were uninsured dropped by about half. And that was because in Massachusetts there was a pretty aggressive outreach campaign. So that's my first suggestion to you is you're going to want to pay attention to how quickly, how much money is spent trying to get people to sign up, how much help there is in enrolling them, and what the actual numbers look like. Because that made a huge difference in many ways initially in Massachusetts. It meant that physicians were overwhelmed initially and are still to some degree in a few pockets of the state. It meant that patients, there were a lot of patients trying to figure out what it meant to have health insurance. If you've been uninsured for a long time, getting care sporadically at a clinic here and there, the notion of having a regular doctor and learning how to use medication on a regular basis is a little unfamiliar. So we had people flooding emergency rooms because that's where they thought you went when you got a cold. And it's taken a while to integrate people into a healthcare system that's really more based on primary care. We're still in the midst of that. We also saw, which you'll see now in the next slide, the effects of pent-up demand, which meant that for many years people had been just covering the basic things they needed. They had not been getting regular physicals or other kinds of checkups. It would indicate longer-term problems or diabetes or maybe a latent case of asthma. So we saw initially, if you can look on this chart now, the difference between 2006, $1 billion being spent roughly on the uninsured, to 2009, where we were at $2 billion. That was the effect of that early enrollment and of pent-up demand. There were some other factors in there as well, but if you can figure out what's happening in terms of getting people on the books, that's going to drive a lot of stories in your coverage. Now, that doesn't necessarily mean that healthcare reform is breaking the bank, because in Massachusetts, the point of this slide is to show you that that very last number you see, bottom of the right-hand column, is how much more Massachusetts spent over a period of 5 or 6 years than was initially forecast. So somebody in your state legislature, I think, will have some forecasts of what is expected to be spent. If you can track how far your state is on or off that, that will be some interesting financial stories. But really, I think what you're going to want to do is follow patients. And in that regard, I think it's very helpful to set up some a database that logs patients, everybody you meet, everybody you're in contact with on email, everybody you see on Facebook or Twitter or any other websites. Log them based on age, gender. You may want to do something about demographics and their occupation. It can be very helpful later when you're trying to find a patient who fits a particular story, because these are going to be such individualized stories. What happens to the people under 30 who sign up for the plans with very high deductibles or co-insurance is going to be really different than somebody who's 55 and is hit with a fairly expensive plan signing up. The difference between people who are in the Medicaid expansion versus the subsidized coverage is going to be very different. There are going to be people who qualify for a waiver because the coverage is not affordable. There are going to be people who expand their employers' roles dramatically because they want to avoid the mandate. I would say look for a doctor who's a primary care, look for a PCP and also for a specialist to follow. a large employer and a small employer. I've got the rest of the categories kind of laid out here. In following the money, who's marketing patients where and why? Who's trying to attract doctors into their new and expanded networks and why? Who's paying the penalty and who is signing up instead? What are the levels of deductibles and such that are allowed or most popular in your exchanges? The resistance, I think, in some states is going to be very interesting, particularly as it hits that the 2014 elections. I mean, Alan, I'd love to hear what you or Becca or others think about this, but I'm imagining that there are going to be quite an expansion of waivers around the time when politicians are trying to get reelected, or maybe Democrats in particular, and they are wondering about all these people who say they can't afford insurance right away. In the exchange, there are going to be all kinds of glitches. Alan talked a little bit about the churn or the bounce rate. People will flow in and out of different categories all the time, which is a headache for them, for their doctors, hospitals, for pharmacists, etc. And some of the exchanges will do a better job at kind of tracking eligibility and making sure that people are going to the right place at the right time than others. So what do you, one of the questions I get asked a lot is, how do you find patients? I think Facebook and Twitter work really well. Some communities have great listservs that would include the uninsured. Churches are a really great place, through schools. The advocacy groups, I'm thinking about, you know, the Diabetes Society, multiple sclerosis. There are many, many groups that know who among their population do and don't have health insurance, and that can be a really good place to look. I already mentioned cataloging patients, and then Becca did a great job of going over the importance of data and finding the best sources. That means also trying to find, in my opinion, the most neutral sources, the sources that aren't trying to sort of manipulate the data to prove one thing or the other, and you'll just have to, of course, figure that out, who that is in your community. Some of the insurers will give you claims data. It's a little bit unusual, but it can be a really great source of information as well. And then many of you, I think, will want to build relationships with reporters in bordering states where the policies that they adopt under the ACA are different, because there's going to be some interesting cross-border commerce, I think, in this regard. We've seen a little bit of that in Massachusetts with regards to New Hampshire and Connecticut and Rhode Island. To track the law, we started a blog called Common Health, because we understood that there were going to be so many different aspects to this law that we were not going to be able to cover either online or on the radio, and we wanted to give the key players a place to come and share their ideas. Alan was actually very generously one of the early contributors to the blog, and it included resource pages, frequently asked questions, calendars of events at one time, advisories. You're going to want to figure out what works best for your audience, but sometimes live events where people can just come and ask questions and kind of share stories. We had some meetup type things. We would do on-air specials periodically, and then just live chats online. And then, oops, I clicked something wrong there. I'm not able to get to my last slide, I think. I'm coming up with some other customized bar. But it just has my contact info, which Michelle or someone else can send you. I'm happy to talk you through anything that comes up at any time, or send links or whatever would be helpful, but have fun. I think this is going to be really exciting.
Thank you so much. That was really helpful, and we will definitely provide the contact information for all of our panelists. So I'm going to open this up for all our panelists and start to just to share some of the questions that we have so far. So basically, one of the questions is for Becca Aaronson. The person asks, the concern about not having enough providers is a legitimate one. What is Texas doing to increase the number of providers available? And this person also mentioned skilled immigrants who are here legally and were doctors, nurses, physicians, assistants, and so on in their home countries. What can we do to make the process easier for them to enter the healthcare workforce?
Yeah, that is a very significant issue, and it is one of the things that when you're trying to understand the opposition to Medicaid expansion, one of the main concerns. In Texas, I know specifically the senator who leads the health committee has numerous bills filed to try and expand primary care coverage. Even the trade groups have given conditional support, like the Texas Medical Association, saying unless the program is reformed and we can bring in more doctors, then we don't necessarily want to expand it because we don't want there to not be enough doctors for the existing Medicaid enrollees. So understanding that question and what's being done is very, very complicated, and it's probably going to be different for every state. But it is essential to understanding whether or not the expansion will happen and what the limitations for expansion are.
Did anybody else want to weigh in on that? So then, I'm sorry, go ahead.
So this is Martha. In Massachusetts, there have been a number of loan forgiveness programs to try to encourage doctors in the community health centers to stay and encourage medical school students to practice in the community health centers. There is still talk here about adjusting payments for primary care docs as compared to specialists, but as you can imagine, that's pretty tricky political conversation and hasn't gone very far.
Yeah, similarly in Texas, there's a movement to raise provider reimbursement rates, but it's tricky and,
I have another question here, which is, shouldn't we be concurrently expanding the redistribution of health providers to rural and shortage areas? And that question is just asked to everybody. Alan, are you able to speak?
Here we go. Yes, let me mention one. Any summary always leaves some important things out, so I should say that another of the many provisions in the Affordable Care Act that I didn't cover in my slides is that in the calendar years 2013 and 2014, states are to increase the payment rates for primary care services provided by primary care providers to the Medicare level, which in some states is quite a significant increase from where they are today. So there is a provision in the ACA. There are many things I didn't cover, but given the question, I think it's important to note that. I want to reply to this and the prior question with sort of two different perspectives. I mean, one is, is it legitimate to have concerns about a sufficient supply of providers? The answer to that is yes. Does that mean we shouldn't expand Medicaid, or is that a reason not to expand Medicaid? I think that's a slightly different question, and so I would encourage you to probe a little deeper. We do have evidence, as I presented to you, that having Medicaid coverage, even with its limitations, is a good thing for people's health, and so and being uninsured is a pretty lousy thing, and so I just think it's important to push beyond the, well, we don't have quite enough providers, and say, well, but does that mean we should leave these people uninsured? The second perspective I want to take, and again, this is a sort of a much bigger topic than we can address here, but there are efforts going on around the country to reorganize and reform how we deliver care. Some of those actually make increased use of primary care, reliance on patient-centered medical homes and the like, and so they place increased demands on primary care. Others actually relieve some demands, for example, by using community health workers and other people with more limited training than physicians or even RNs to help people manage their care. We have a payment system right now where you only get paid if you see the doctor. If you can get paid for keeping someone healthy, and the best way to do that is to have them visited by a community health worker, we've solved two problems at once. We've reduced costs, and we've actually reduced the demand on the providers, particularly the providers in tightest supply, the physicians and the nurses, by extending their ability to care for their patients by using other workers. So this is not a static situation. It's not, we have X number of people served by Y doctors, and if we increase X, we need more Y. It really is a very dynamic delivery system that we're working in. And as that evolution occurs, the projections of what we need in terms of providers is also going to change. So it's just important to look a little bit under the rock of the basic notion that more people means more unmet need.
So we're seeing a bunch of questions here about non-participating states, and I will just sort of try to summarize a couple of them. One question asks if non-participating states are putting themselves in a legal quagmire with potential class action suits by healthcare advocates. Another question asks, will non-participating states be able to retroactively participate? So I don't know if any of you want to take a crack at that.
I can answer both those pretty easily, I think. In terms of retroactive, this is not a permanent decision, but it cannot be changed retroactively. So a state can expand at any time, January 1st, 2014, June 1st, August 1st, and they can reverse their decision at any time. Some states have talked about going in for the first 3 years when the federal government pays 100%, and then potentially changing their mind when the state share goes to 5%. So this is not an irreversible decision, but it can't be changed retroactively. As to the legal challenge, I guess you can challenge anything, but I think the Supreme Court has actually spoken with a good deal of clarity. There really is no cause of action to challenge a state's decision. And I don't really know, again, you can sort of come up with you can come up with something, but I'd have a very hard time imagining a basis for a legal challenge to a state's decision here when the court has spoken with as much clarity in this circumstance as it has.
Any of our other panelists want to weigh in on this?
I mean, that's definitely something that's being considered in Texas, is whether or not, if they did participate, for how long, or if they would include maybe a provision to stop participation if the federal level of financing changed or went down.
So another question here, which is there any fear that individual preferences or just expectations being disappointed will lead to a poor uptake of this Medicaid expansion?
I'll go ahead on that one as well. If you remember the data I showed you that said that there would be increased Medicaid enrollment even if no state elected the expansion, the reason for that is we do have many people who are currently eligible for Medicaid and they are not enrolled. And the idea, the thinking behind that estimate is that there's going to be a lot of attention paid to these new health insurance exchanges, to tax credits, subsidies to make coverage more affordable. There's a whole marketing campaign being planned. And with all of that marketing, a bunch of people are going to come in and apply for the exchange, but their income will actually be lower than exchange eligibility, and they'll, in fact, be Medicaid eligible and then get enrolled in Medicaid. So we know that marketing and public information about these programs matters. We also know it from children's coverage. When Illinois, some years ago, adopted universal health insurance for children, the uptake rates, the take-up rates went way up, not just because they expanded eligibility, but because they were sending a very clear message that everyone is eligible for something. Every child is eligible for something. So come on in and we'll figure it out for you. I think if the country was going full speed ahead, implementing every aspect of the Affordable Care Act, we would see pretty high rates of take-up in January. Now we're getting this very mixed message. The Kaiser Family Foundation has done surveys showing that a quarter of people a year ago thought the law had already been repealed because there's so much talk about repeal. So I think the more the message is mixed, the more people who oppose the law pretend it's not there, the more states don't take up the Medicaid expansion because they don't want to, or they don't market the exchanges because they're not supportive of the law, the more people are going to be skeptical about whether this program is really going to be around, whether it's worth the trouble, whether they should trust it, and the enrollment rates will be lower. We do know that a clear message of coverage does make a difference on enrollment.
Becca and Martha, are you finding that this is a story for you, just the confusion and also people who are ambivalent about coverage?
I'm not, I mean, we had actually very little, this rolled out surprisingly smoothly in Massachusetts, and we had tons of stories of people, I don't know, sometimes people think the water is just different here, but we had tons of stories of people who were so thrilled that they found this mass that was, that, you know, 3 years from then would have killed them. Or I remember being in a ceramics class with my teacher talking about how he had insurance for the first time in 10 years and had fixed his glaucoma so he could see. He wasn't just throwing pots, you know, based on the feel. So they were kind of amazing. I mean, healthcare is important, right? People like having coverage, which is not to say that they want to pay for it. That's the whole difference. They like getting the services. They do not believe that it should cost as much as it does, and I think that's where the rub is.
Becca, any thoughts on this?
Yeah, well, there is a lot of confusing information in Texas right now. I wouldn't necessarily say misinformation, but I would say that there's so many different perspectives that sometimes the arguments don't necessarily align on the same page, and people, you know, can't figure out what they agree on and what they don't. Because for some in Texas, the financial impact of Medicaid is most important, whereas for others, it's quality of health and insurance coverage, or expanding that coverage. So that's where a lot of the confusion, I think, lies here from a policy standpoint.
We have a question here about mandatory enrollment in HMOs. One listener says, why do states find expanding Medicaid by mandatory enrollment in HMOs so appealing, and what are the advantages and disadvantages for insurers and patients?
Well, I can, let me take 3 perspectives on that. One reason to like HMOs is because of budget certainty. If you're paying claims on your own, you have estimates of what it will cost, but you don't know. Whereas if you pay a managed care company a fixed amount per person in advance, other than changes in enrollment, you know what your cost is going to be. So there is some budget certainty. The second is the ability to invest in an infrastructure of care management and care coordination. We know that people who get their health care through some sort of an organized system of care are more likely to get the care they need, not get care they don't need, have their chronic conditions better managed. Not all HMOs do that, I should be clear, but some do. And if you're not in a system like that, you probably don't have any of that care coordination. And so there's a legitimate goal here of improving care coordination. And the evidence is mixed, but generally positive that for at least the moms and kids who went into managed care and Medicaid a decade or so ago, more than that actually, 15 years ago, that there were small improvements in quality. The final reason is sort of ideological / political, which is that when you say they're in managed care, you can call it private insurance, and I suppose it is, even though the taxpayer is paying the bill. And if you really want to be cynical about it, you've created with those managed care companies a very large supply of campaign contributors and political donors who care a lot about the program. And some of that flows back, hopefully not in corrupt forms, but at least in campaign contribution forms to the politicians who are sending the business their way. And so it does create another advocacy constituency for the program that otherwise wouldn't exist. So there are many reasons for it, some that are very good for patients and taxpayers, and some that are a little more questionable.
We have somebody asking about using data and whether this is a way to stay above the partisanship And I wanted to maybe turn this over to you, Becca, first, because you said that you felt that data could be quite political. Did you want to take this question?
Yeah. So data, it can be used for good and for bad. I mean, it depends on the presentation, and it depends on the source of the data. So if, I mean, Martha hinted at this, you want to be very careful that you choose data that hasn't already been corrupted for a political or partisan agenda. So some of the best places to look are really actually nonpartisan groups or the state, and just get raw data and try and present it as reasonably as you can. But always take it with a grain of salt. I mean, you want to make sure that you present it in a way so that your readers can look at it, they can see the biases, and then they can take it and kind of interpret it in a way that's reasonable about how it will affect them. So you do need to be careful with data presentation.
And I have a question here from California, but perhaps it could be expanded to really address anybody in a state with a large uninsured, low-income, and Spanish-speaking population. The question is, in California, how well is the health exchange, how prepared is the health exchange to promote services to the uninsured and low-income Spanish-speaking populations? Alan, do you want to take this?
I don't think I can really speak to California with specificity. The federal regulations are quite clear, and California has been working on its exchange for some time. But, you know, I think knowing what I know about California, language access is a huge issue and is on the minds of state officials running programs every day. So I don't want to be a Pollyanna about it, but I am certain this is very much on the minds of those who are running these programs. As to how it's playing out, I can't speak to that.
We also have a question from somebody saying that in the medical field, there are people who worry that the Affordable Care Act will force doctors to accept patients and really lower their own reimbursement rate. Is there any truth to that?
I hope so. Oh, I'm sorry. Did I say that? Yeah. You know, force is an interesting choice of words here. There's no requirement in the Affordable Care Act that physicians take Medicaid patients, that they take Medicare patients, that they join accountable care organizations. All of these things are optional layers on top of the existing fee-for-service system in which most of them operate. But I think over time, I think we're less likely to see direct payment cuts than we are to see, and Martha can talk about this in great detail because Massachusetts is really at the forefront, reorganization of the healthcare delivery system in ways that are more based on population health outcomes that move away from paying for every service delivered. And at the unit level, it may appear to be a cut, but it's not as if it can't be accounted for by improving how you deliver care. So it's the dynamic nature of healthcare delivery that I think is missing from the premise of the question. If you just ask, will there maybe be less, the answer is maybe there will be less. If you ask, is there a way for hospitals and physicians and others who deliver care to succeed in a healthcare system that is more efficient and more affordable to taxpayers, families, and employers? The answer is yes, but they might have to change a little bit about what they're doing.
We have another question from somebody asking about Oregon and whether that is a model in any way in terms of, I think, dual eligibles for what's happening in the U.S. more broadly. Alan, I'm going to ask you if that's something that you feel comfortable replying to.
Oregon just received a large waiver from the federal government to change how it purchases care for its Medicaid enrollees, and particularly their focus right now is on integration across physical health, mental health, and oral health In the healthcare world, these are very separate ecosystems. I mentioned earlier that mental health is a major cost driver among the Medicaid population. I didn't mention oral health, but it is also true. And Oregon, with Governor Kitzhaber at the helm, is at the forefront of exactly the topic that I keep alluding to somewhat at an angle, which is changing how we deliver care, changing how we pay for care to support more efficient delivery. The Institute of Medicine recently reported, and I think there's much evidence to support this, that 30 or 40% of what we spend on healthcare provides no value, no clinical value in terms of better health or better outcomes. And you know, we're all paying for that 30%. And so I think Oregon's a very interesting state to watch to see how successful they are in some of the redesign of healthcare delivery, the integration across silos, the changing of payment. It's too early to call anyone a success, but they are certainly trying to do something that is out at the front of what is going on around the country.
We have another question, somebody asking for resources for looking at Spanish language outreach. Any suggestions? In other words, to find out about how good of a job exchanges are doing in various states with reaching out to Spanish-speaking populations.
There's an organization in Massachusetts called Healthcare for All that they ran a lot of or helped supervise a lot of the early outreach programs in Massachusetts. I don't remember what they did that was specific to native Spanish speakers, but somebody there could tell you.
And Javier, we'll try and
there's
I'm sorry, go ahead, Alan.
There's a relatively new organization called Enroll America that is dedicated entirely to outreach and enrollment. And I can't say whether or not they have information in this area, but again, that's the kind of thing they would probably be looking at.
So unfortunately, we have about 1 minute left, and I have a sneaking suspicion that this webinar may end whether we want it to or not. So I want to take a moment to thank all our panelists, Alan Weil, Becca Aaronson, Martha Bebinger, and to thank all of you for asking such great questions. I just want to remind you you'll be getting a survey in about an hour, and that this recording will be put up tomorrow on Reporting on Health. You'll get a link with that and with information including all the PowerPoints. Thank you so much, and please join us for our next webinar as well.